Hello, I'm John Inadomi from UCSF. I'm joined today by Dr. Bret Spier, who's a third-year fellow at the University of Wisconsin School of Medicine. And today we're going to talk about his article entitled Colonoscopy Training in Gastroenterology Fellowship, Determining Competence. Welcome, Dr. Spier.
Thank you very much.
Great. Actually, the first question I want to ask you is, how did you come up with this particular project?
Well, at the beginning of our fellowship, our program director asked us to come up with a quality improvement project. And so this is actually one of the ones that I devised and I've carried through during my 3 years of training, and it's culminated in the publication of this manuscript.
That's wonderful. I mean, it really is an inspiring kind of story for other fellows to actually hope that they can also achieve. It's really a good story there. Now, in terms of this particular study, I noticed that you have a primary outcome. And why don't you tell me about the outcome and how you devised this outcome to be the most important aspect of this quality improvement measure?
So our primary outcome was to look at independence, which is our surrogate marker for competence or procedural competence. And the current guidelines suggest a threshold of 140 colonoscopies by the end of your training. and so we wanted to know where our fellows were independence-wise at attaining that measure. And so independence is with the endoscopist or the colonoscopist, the supervising colonoscopist, not touching the scope at all. And so we use that as our surrogate versus cecal intubation rate. We also use it as 90%, which kind of correlates with some of the cecal intubation numbers for practicing gastroenterologists and what they hope to obtain.
Sure. Now, this is really cutting-edge kind of research, so it's unlikely you were able to find any kind of validation studies about this particular outcome, but certainly from a clinical perspective, it makes perfect sense, so I really like that. Well, why don't you tell us about the study and the results that you found?
So overall, what we found was that after 140 colonoscopies performed, we didn't have any fellows that were actually meeting that benchmark of 90% independence, and that it took the best or the fastest was 330 colonoscopies to reach that 90% independence. The other outcome we found was that by 500 colonoscopies performed, all of our fellows met that 90% independence, which meant that throughout the fellowship, everybody would be adequately trained using that measure.
Excellent. That's actually very fascinating. One of the other secondary endpoints you had was adenoma detection. And I noticed in your article that there was actually no increase in adenoma detection over time. So why don't you interpret that for me?
Right. So with respect to adenoma detection, in practicing gastroenterologists, there are thresholds, there are benchmarks of approximately 0.4 adenomas per patient that should be detected. But again, in our study, we didn't show that there was any change over time, primarily because we had supervising gastroenterologists during the procedure watching over us to make sure that we didn't miss any polyps. And so that really speaks towards why there was no change in that over time.
Great. Now, as you pointed out, the standard for gastroenterologists is about 140 colonoscopies prior to assessing competence. And you realize also that for the surgical specialties, that threshold is much lower. It's about 50 or 60. This is actually after being upgraded compared to previous recommendations. So tell me about what your consideration, in light of your study results, what are the implications for training at this point?
Well, in colonoscopy and GI fellowship training, by far, we receive way more than 140 colonoscopies. And so, for the most part, it doesn't really impact that aspect. But for the non-gastroenterology programs, the surgical subspecialties, and then even the family practice residencies that do obtain right around that 50 to 60, it may suggest that we need to increase that bar substantially.
Yeah, I would agree completely. Now, I'm very interested in your career as well. So where are you going to take this? I mean, you're a fellow now. I want to know what you're going to do with this and with your life.
Yeah, well, my program director has accompanied me, and we've been talking a lot about where to go from here and what standards we need to implement in not only the fellowship training, but then in the practicing endoscopy suite as well. And so we're going to bring a lot of this, the withdrawal time, to the staff as well. We're also currently training surgical residents in colonoscopy, and so we're going to bring some of this study to them as well, just to see where they are with respect to independence or cecal intubation at their current thresholds. And maybe we'll show that it's inadequate and that changes need to be made.
Agreed. Very good. Well, Bret, thanks so much. I really appreciate the time. Really enjoyed your study, and I think it's a real testament to your program as well as to the kind of aspirations that we should have for our fellows to provide high-quality, impactful research. And I look forward to more work from you and your group in the future. Thanks so much.
Thank you very much.